Good afternoon, everyone. I'm just waiting for to see if anybody turns up, and then we'll start in 5 minutes. I think I'll make start. I don't think so anybody's coming face to face on the site. We were hoping a few more people could join face to face. Can you all hear me all right? And see me? Yes, no? You can type in the chat if you all can hear me or see me all right. And then I'll start with the talk. Is it Sarah, Jamal, Amelia? Can you see me all right? Hear me all right? Okay, can you see the presentation at all? Or do I need to share screen? So I'm just going to presentation here. Type in if you can see it. Okay, great. Right, yeah, so I'm going to start the presentation. It would have been really nice if you could do it face to face and I could talk to you, even if there's 3 of you. But yeah, it's not possible because I think I'm in Boston site and you're based in Lincoln. Yeah, so today what I'm Reema Rambani and I'm the microbiology consultant. Now I can't, if you want to ask me a question in between, in that case, you can just type in the chat. I'll try and keep some time for question and answers towards the end of the talk. Yeah, So let's make a start then. So I don't know how much background knowledge of microbiology and antibiotics you all have. Do you want to tell? Anybody wants to unmute and say what is the background in microbiology and how much knowledge do you have? Anybody wants to say anything? Yes, no, maybe? Okay. Well, today what I'm going to present is just a basic overview of microbiology, and yeah, knowledge is power. So the more knowledge we have, the more powerful we are to be able to make decisions when we are on the ward and when we're dealing with the patients, and we can understand things better. So today what I'm going to do is a rough guide to microorganisms and a survival guide to antibiotics. Just a very, very basic lecture to get the foundation strong. Once the foundation is strong, then you can build up on it. So the SMART objectives are that hopefully by the end of this lecture, you should be able to name 2 bacteria in each category based on their shapes and gram stain, describe 2 general sites of infection of gram-positive and gram-negative bacteria, and name 2 antibiotics to treat the gram-positive infections and 2 for gram-negative infections. So basically, when we the microbiologists, they basically deal with bacteria. I mean, microbiology covers other branches as well, mycology, parasitology, and virology is a separate big division as well. But I'm only going to focus mainly on bacteriology. So we're going to mainly talk about bacteria today because there's only limited time, and that's my expertise. That's my area of expertise. So bacteria. So basically, the bacteria are divided into different types, and the basic point of division is the shape. So bacteria can be mainly broadly categorized into 2 shapes. Either they can be round in shape when they're called cocci, or they can be bacilli where they're rod-shaped. And this is the basic structure of bacteria that they have. The most basic structure of any bacteria should have a cell wall. And inside the cell wall, there would be a cell membrane. And inside that, there is a cytoplasm. And cytoplasm has nuclear material, which is DNA or RNA. And and also there will be some ribosomes, which will do the protein synthesis. So the most basic bacteria should have these basic structures in order to be able to survive. Now, different bacteria could have some extra structural features, like some bacteria have a capsule. Pneumococcus is known to have a capsule. Some could have a flagella, which makes them motile. Some could have pili, which are like smaller form of the motility structures, which help the bacteria to move from one place to another. And some bacteria have spores, which give them like a resistant shell outside them and help them to survive in the environment for a long period of time. For example, C. diff, you would have heard of. There's a lot of emphasis on the wards on trying to prevent the spread of C. diff from one patient to another. And the reason for that is that this C. diff or Clostridium difficile can survive in the environment in the form of spores, and it can easily then pass on from one patient to another patient and can lead to outbreaks and all. So and what is this differentiating feature that divides this bacteria into gram-positive, gram-negative, and mycobacterium? So one way to divide them is on the basis of the shape, that they are cocci or bacilli, they are round-shaped or they are rod-shaped. And the other way to divide them is into gram-positive, gram-negative bacteria. Now, the gram-positive bacteria, I'll show you later on in the slides, when we stain them, there's a gram stain in the lab, and when you stain them in a pink background, they look purple. And the gram-negative bacteria against the pink background look pink in color. And then there are mycobacterium as well. Now, the difference is because of the difference in the cell wall of these bacteria. The gram-positive bacteria have got a thicker peptidoglycan layer. As you can see here, this is the peptidoglycan layer. So the gram-positive bacteria have got a thick peptidoglycan layer, and that makes them appear purple because they retain the stain. That's the gram stain, and they appear purple in the slides. The gram-negative bacteria have got a thinner peptidoglycan is half the size of the gram-positive bacteria, the peptidoglycan layer, and they've got some extra things in their cell wall, which is lipopolysaccharide, which leads to the, if we get, if a patient comes with gram-negative infection and they have a sepsis, then lipopolysaccharide is kind of, it's the one that's triggering that sepsis response in the body. And mycobacteria, the one which are most important one is the Mycobacterium tuberculosis. They are called mycobacterium because they have a thinner peptidoglycan, but they have got some specific structures called mycolic acids in their cell wall. I'm not going to touch the mycobacteria today, but that was just to give you a differentiation. And as I said, so they could be divided into cocci, gram-positive cocci and gram-negative bacilli, and then gram-negative cocci, and then into rod-shaped ones are divided further into gram-positive rods and gram-negative rods. Gram-positive cocci, the most common ones are staph and streps, and another type of streps, there are different types of streps, and enterococci are kind of streps as well. And the ones in red, peptococci and peptostreptococci, are anaerobes. They can only survive in the absence of oxygen. Gram-negative cocci, when you see them, the most common ones are Neisseria species, Neisseria meningitidis, Neisseria gonorrhoeae, Moraxella, Acinetobacter. The gram-positive rods, so the Clostridia that we were talking about, Clostridium difficile, Clostridium tetani, Clostridium perfringens, botulinum, they are all different types of Clostridia. They are gram-positive rods. If you look at them, look on them in the lab under the microscope, then they appear as purple rods, gram-positive rods. So they could be Clostridia, they could be Corynebacteria, and Listeria, which causes meningitis, and Bacillus species like Bacillus anthracis or other aerobic spore bearers could be Bacillus as well. And all of these categories have some anaerobes in them. So Clostridia is the anaerobe. Then gram-negative rods are a biggest section, and the gram-negative rods are further divided into lactose fermenting and non-lactose fermenting. I'll show you. We have further media in the lab to differentiate them into lactose fermenting and non-lactose fermenting coliforms. And these could be oh, are the slides not showing? I thought I was sharing the slides and you should be able to see the slides. Are you not see the slides? I thought I was sharing and you should be able to see the slides. Can you please type and tell me if you're able to see the slides? I've stopped sharing. Well, or Anya, can you please come in this room and to share? Because on my screen, it just does say that it's sharing. Is it not sharing? No. So if I look here, it says it's sharing. Is it just sharing this window?
Yeah, this is what it's showing.
All right, okay. Share the slides then.
Okay. Just minutes a second. Go to stop sharing. Share. Select that option.
Is it this one?
No, that's not that document. Oops, what about that other one? Go back to the window.
Sorry?
Go back to the window.
It's not giving the option of sharing.
It's not, no. Try going up to the meeting room and share that.
That's what I did.
And try clicking onto the PowerPoint.
And that's what I did here.
Really? Oh, wait, put it on slideshow. Okay, now if you drop down your mouse down here. Oh, hold on a second. Try select. Just this one.
Usually it should give you the option here, isn't it?
It usually should, but for some reason it's not.
Should I leave and go back in again? Would that help?
Yeah, try that and see if it refreshes itself once you come back in. Try window. What about entire screen?
If I do entire screen,
Would it work if you click on it? No, it should. Try going. Okay.
oh, right, okay. So I start from the beginning because they haven't seen any.
If you're comfortable with that.
Yeah, that's fine.
Okay.
Yeah, can you ask them, can they see it now?
Can you guys see it now?
Can somebody?
Yes, right. I can see it.
Okay, sorry about that. So I'll start from the beginning again.
Yes, we can see it.
Fantastic, yeah. So yeah, so I was going to, yeah, right, okay. So yeah, I'm going to give you a rough guide to organisms and survival guide to antibiotics. And I was saying that the objective is that you should be able to name 2 bacteria in each category based on their shape and gram stain. By towards the end of this lecture, you should be able to describe 2 general sites of infection of gram-positive and gram-negative bacteria and name 2 antibiotics to treat the gram-positive infections and 2 for gram-negative infections. So basically, the bacteria, I was saying, are divided on the basis of their shape. And on the shape could be like round shape, where they could be cocci, or rod shaped, where they are called bacilli. And this is the structure of bacteria. And the most basic structure is that they should have a cell wall and a cell membrane inside the cell wall. Then there would be a cytoplasm with ribosomes in it. And then there's nuclear material with DNA and RNA. And the ribosomes are the protein synthesis machinery of the cell. And some bacteria could have some extra structures like capsule or flagella or pili or spoke. And I was showing here that the difference in the structure and the difference, basic difference that makes them gram-positive or gram-negative or mycobacteria is based on their cell wall. The gram-positive bacteria have got a very thick peptidoglycan layer. The gram-negative bacteria have a much thinner peptidoglycan layer. It's like half the size of the gram-positive bacteria, and they've got some extra structures called lipopolysaccharides in their cell wall, and that is the one which induces the septic shock with the gram-negative bacteria, because the body reacts to these lipopolysaccharides. And the mycobacteria are called mycobacteria because they have mycolic acids in their cell wall. So this is the differentiation, and as I said, the gram-positive could be, so on the basis of these 2 things, we could have gram-positive cocci, gram-negative cocci, gram-positive broths, and gram-negative broths. So the gram-positive cocci, the most common ones are Staph and Streps. The gram-negative cocci, the most common ones are Neisseria species, Meningitidis and gonorrhea, Moraxella and Acinetobacter. Gram-positive rods, the most common ones are Clostridia, Listeria, Bacillus, and Corynebacteria. And gram-negative rods is the biggest section, as you can see. Mostly they live in the gut, And they are further differentiated in the lab based on how they grow and the reactions that they do in the media that they grow in. And the most commonly used agar in the lab to grow the gram-negative rods is McConkey agar. It has lactose inside it. And if they ferment lactose, then the media turns pink in color, and the lactose fermenters are E. coli, Klebsiella, Enterobacter. And if they don't ferment the lactose, the media doesn't change into pink color, it stays colorless. And then it could be Proteus or Pseudomonas or Salmonella or Shigella. And other gram-negative rods could be Haemophilus. Helicobacter, Campylobacter are not exactly straight rods, they're like curved rods. So yeah, the morphology helps to find out what they are. So just to give an example, this is like a pink background, and these are slightly darker cocci. These are actually purple clusters of gram-positive cocci, clusters like grapes, and that's typically gives the technician who's looking in the lab under the microscope, he's stained the slide and he knows, oh, it looks like it could be a staph. And these are with a pink background, these appear purple and they are in chains. So these are gram-positive cocci in chains are typically going to be some kind of streptococci. So this is a pink background with purple cocci, and they are diplococci, if you see, like they're clusters of two together. And gram-positive diplococci typically give an idea that it's going to be some sort of a strep, and most likely it's going to be a pneumococcus. And then you have to do further tests in the lab to find out exactly what it is, but it gives an idea. So these are like the purple rods, so gram-positive bacilli. And when the lab and somebody looking at them, they think, oh, gram-positive bacilli, it could be Clostridium, it could be Bacillus, it could be, it could be Listeria, but Listeria usually is not that thick. So these are looking like pink rods in the gram film. And as I said, gram-negative rods, that's the biggest section. It could be anything. It could be E. coli, Klebsiella, Enterobacter, Proteus, Pseudomonas. So the lab will have to do further tests to be able to find out exactly what this is. And these are pink background and pink diplococci. And these pink diplococci are gram-negative diplococci are typically going to be some kind of Neisseria. It could be Neisseria meningitidis or Neisseria gonorrhoeae or something like that. So they'll have to do further tests. So once they look in the gram stain in the lab, then after that, we have to grow them on different kind of agar. If it's a strep or a staph or something, you could grow them in agar with different things in it, which again helps the lab to identify what bacteria it is exactly. And the most common media used in the lab is a blood agar. It could have sheep blood or horse blood inside it. And then based on the morphology of the colony next day, after incubation for 24 hours, the lab again will have to find out exactly, it gives an idea of what exactly it could be. So if it's a staph, then staphs are further, if they are gram-positive cocci, then we have to do a test in the lab called catalase test. If they are catalase positive, they are staphs. If they're negative, they're streps. And, you have to do further tests to find out. And then if it's a staph, then in the lab, they will do a further test, which is a coagulase test, which helps to find out whether it's a staph aureus or it's a coagulase negative staph. If it's a coagulase positive, then it's a staph aureus. If it's coagulase negative, then it's a further big differentiation, and there are about more than 40 species of coagulase negative staph. Staph aureus is usually pathogenic. Coagulase negative staph is usually normal skin flora, but there are different species of it. Staph hominis, staph capitis, staph hemolyticus, lindinensis, lots of different species. As I said, most commonly normal skin flora, but they have got the potential to cause infection, especially if somebody's got metalwork in there, somebody's got lines in any kind of foreign body, valves in the heart, any catheters and things, then it tends to stick onto those areas, and they can cause infection. And if it's a strep, then again, the lab would try to grow them on the blood agar, and depending upon the type of hemolysis, they would get some idea of what kind of strep it could be. So if there is a horse agar or sheep agar, you've grown streps on the plate, and you see a green zone of hemolysis, which is due to bilirubin production from hemoglobin degradation, but it's like partial degradation of the blood cells, not full degradation, then it's alpha hemolytic strep. And alpha hemolytic strep either could be Streptococcus pneumoniae, which is definitely pathogenic, or it could be a big branch called strep viridans. The strep viridans are usually normal mouth flora. If they do a complete hemolysis of the red blood cells, then we call it beta hemolytic strep. Now, beta hemolytic strep usually are nasty. I've seen people lose their limbs because of beta hemolytic infection or a strep infection, or sometimes they can die of sepsis as well. These are further divided into Lancefield groups. There are about 21 Lancefield groups, like A, B, C, D, different alphabets. And group A, C, and G are known to be nasty. And there are other groups as well, like group B strep. It's so basically lab will have to do some sero grouping, and then they find out exactly what it is. Group A strep is also called strep pyogenes. Group B strep is also called strep A galactii, and that's known to cause infections in neonatal sepsis, and it's a normal vaginal flora in the females, and that's why when the ladies are pregnant, then they could be screened for group B strep, and if they are found to have a group B strep, then they receive intrapartum penicillin prophylaxis to prevent the infections in the newborns. And then there are other types of beta hemolytic strips as well, and then there is gamma hemolysis as well, where there is no hemolysis around the red blood cells. For gram-negative rods, as I said, it's fermentation. So this is McConkey agar, and if it's pink in color, then they're lactose fermenting gram-negative rods, coliforms. And then we know that if they're pink in color, it could be Klebsiella, E. coli, Enterobacter. And if they are, colorless, then they are non-lactose fermenting. They could be Pseudomonas, Proteus, Salmonella, Shigella. Still in some labs, we have another test called API, which is again a combination of biochemical tests, which gives you a number profile, and it helps the lab to find out exactly what the bacteria is. And once the lab knows what the bacteria is, then we have to do antibiotic sensitivities in the lab, and one is the disc diffusion sensitivities, where patient sample is inoculated in the agar, and then different antibiotics are in these discs, and you put the discs and then incubate them and see the next day. If there is a zone of inhibition, then we know that the bacteria are being killed by that particular antibiotic. If there is no zone of inhibition, that means the bacteria are resistant to that particular antibiotic. And if there's an intermediate zone, then we know that it's partially killed. And if we want to know the MIC, the minimum inhibitory concentration, specifically for infections which are deep infections like endocarditis, discitis, and all, we want to know exactly what concentration or what dose of antibiotic should be used to kill the bacteria and get rid of the infection. Then we do a test called E-test. It's got this one antibiotic, but in different grades. The concentration gradient is there in this strip. And where you look at the point where it starts inhibiting the bacteria, and this is the minimum. Can you hear me? All right, everyone? Yeah, so you need to see the minimum inhibitory concentration specifically to treat the deep infections. Okay, so that was a basic overview of bacteria. Now coming on to antibiotics. This is just a survival guide to antibiotics I'm going to give you today. So it would have been really good to have you face to face, and then I would have asked you questions, but I can't. So for gram-positive agents, the most commonly used antibiotics, which you would have seen on the boards, are flucloxacillin, penicillin, and amoxicillin. These are different kind of beta-lactams. Then for other agents that can be used, if the patient is penicillin allergic, usually they would be allergic to most of the beta-lactams if they're allergic, but it depends exactly what happens if they're allergic. If it's only a rash, you could still use some other options, and if it's anaphylaxis, then you may have to use different group altogether. So the other options are macrolides, which are like clarithromycin for gram-positive agents. Clindamycin is a lincosamide. Doxycycline you can use, or vancomycin, tacoplanine could be used. Linezolid could be used. Daptomycin. Fusidic acid and rifampicin could usually be used in combination with another antibiotic. Now, gram-positive agents, I said, as I explained previously, are staph and streps are there. And if it's a staph, it could be a fluclox sensitive one, MSSA, or if it's a fluclox resistant one, it could be MRSA. So for MRSA, all of this won't work. But vancomycin, tacoplanine, linezolid, daptomycin will definitely work against MRSA. And we do the testing, and they could be sensitive to clarithromycin or clindamycin or doxycycline, or there's another one missing in this list, which is cotrimoxazole. So those could be used for MRSA specifically, but beta-lactams don't cover MRSA. For gram-negative bacteria, as I said, there are gram-negative cocci, Neisseria species, Moraxella acinetobacter species, and gram-negative rods, the huge group of coliforms. We could use, there are mainly three big guns, which are beta-lactams, and depending upon what the organism is and how severely septic the patient is, you have to have a hierarchy in your head, which starts with amoxicillin, goes up to co-amoxiclav, and then tazocin, and then goes up to carbapenems, and somewhere in between comes cephalosporins as well, and there is aztreonam. If they are allergic to beta-lactams, which so many of them are labeled as penicillin allergic, you need to know exactly what the kind of allergy is. Once again, you need to exactly find out. Sometimes they could just be having nausea or some intolerance to antibiotics, and they are falsely labeled as penicillin allergic. So that's why we tell you to find out exactly what happens. If it's rash, it's a definite allergy. If it's anaphylaxis, it's a definite allergy, and then you would try to avoid these antibiotics. Then other options could be aminoglycosides, which is like gentamicin, tobramycin or amikacin, quinolones like ciprofloxacin, levofloxacin, and another old antimicrobial, which we were not using that much, but it's sort of emerging as an option, is cotrimoxazole and also chloramphenicol. These are old antibiotics, but they were not being used that much because of there was a feeling that these could lead to side effects, but it's not that as bad. So cotrimoxazole is a combination of trimethoprim and sulfa drugs, and that works against both gram-positives and gram-negatives, and chloramphenicol works as well, and those other options. So for atypical bacteria, as you know, when a patient comes in with a community-acquired pneumonia, they could have a atypical infection, and atypicals are mycoplasma, chlamydia, and all these organisms which can cause this community-acquired pneumonia. And these organisms are called atypicals because they don't have a cell wall. So that's why any antibiotic which is targeting the cell wall won't be able to work for these bacteria. So that's why the choice for these, you would have seen usually for community-acquired pneumonia, the combination of co-amoxiclav and clarithromycin is used. So clarithromycin is to cover the atypicals here. So and other option are ciprofloxacin, moxifloxacin, levofloxacin, and doxycycline. For anaerobes and all the different categories of antibiotic of bacteria, I told you that there could be anaerobes, and anaerobes are just could be any shape or any ground stain, but they are the ones which are not able to grow in the presence of oxygen, and that's why usually you would find anaerobes growing in the body where there are abscess. And deep inside the abscess, where there's not much oxygen, you would find anaerobes. So if there's any abscess anywhere in the body, you would try to give an antibiotic which covers the anaerobes. And it could be metronidazole, it could be clindamycin, it could be amoxicillin, co-amoxiclav, tazocin, ertapenem, meropenem, depending upon where the infection is and how big the infection is. That's the same one. And all these antibiotics, which I've told you, they would target different parts of the bacteria. So the cell wall is the most common target. And for cell wall, we have the beta-lactams, as I explained. These are mainly targeting the cell wall. The glycopeptides, vancomycin and teicoplanin also target the cell wall. Daptomycin targets the cell wall. Then there is colistin, which targets the outer cell membrane. There are protein synthesis inhibitors, and these are aminoglycosides, tetracycline, clindamycin, linezolid. They all are protein synthesis inhibitors. And then there are nucleic acid inhibitors. And these are DNA gyrase, topoisomerase inhibitor, which is ciprofloxacin, levofloxacin. Then we have and this slide is actually telling the same thing as well. So the cell wall inhibitors, transpeptidase inhibitors are penicillin, cephalosporins, vancomycin. The outer cell membrane inhibitors are polymyxins, colistin. The ribosomal protein synthesis inhibitors are gentamicin, tetracycline, clindamycin, linezolid, and the nucleic acid inhibitors are ciprofloxacin is for DNA topoisomerase, rifampicin, RNA polymerase, cotrimoxazole, folate synthesis, and metronidazole, DNA damage in anaerobes. So they've got different mechanisms of killing the bacteria. And also they are divided into bactericidal versus bacteriostatic. So beta-lactams are bactericidal. They kill the bactericidal, basically kill the bacteria, and bacteriostatic stop the further multiplication of bacteria. But they're both equally effective. But if it's a deep infection, if it's like endocarditis or something, then you try to avoid using bacteriostatic and use bactericidal agents. Beta-lactams, glycopeptides, fluoroquinolones, colistin, daptomycin, aminoglycosides, they're all bactericidal. And tetracycline, clindamycin, sulfonamides, trimethoprim, chloramphenicol, linezolid, they are bacteriostatic. And macrolides are sort of in between. So now we put the two together. If there are gram-positive infections, as I said, they could be staph and streps. If it's Staph aureus, the most common antibiotic you would try to use to treat this infection would be flucloxacillin, clarithromycin, or doxycycline or clindamycin. Staph aureus usually would cause cellulitis, or it can cause, basically skin and soft tissue infections, but it can also sometimes go into the blood and then seed onto heart valve to cause endocarditis. It can go into the spine to cause discitis. It can, if there's any metal work in the body, it can go into prosthetic joint infections, or even septic arthritis and osteomyelitis for native joints and native the bone as well. So bone and joint infections. And MRSA, again, could cause similar infections, but as I said, for that you'll have to use vancomycin, teicoplanin, or linezolid. Streptococci, most common cause of sore throat, sinusitis, again cellulitis as well. And then they can cause deeper infections like endocarditis and again bone and joint infections as well. So Ben-Pen is commonly used, and they're usually pretty sensitive to simplest antibiotics like benzyl penicillin, or you can use amoxicillin, clarithromycin, and all these. Enterococci, now enterococci, so these are called enterococci because they live in the gut. And because they live in the gut, the most common infections they can cause are urinary tract infections, but they can also cause endocarditis and things like that. And you have to specifically use antibiotics like amoxicillin, vancomycin, teicoplanin based on the sensitivities. For gram-negative cocci, as I said, could be, most important ones are meningococcus and gonococcus. So for this, you have to use third-generation cephalosporins, only those antibiotics which can cross the blood-brain barrier. So it would be cefotaxime or ceftriaxone. For gonorrhea, it could be ceftriaxone, azithromycin, or doxycycline. Coming on to gram-positive warts, we know for C. diff on the warts you would have seen we can use metronidazole, but more commonly we use oral vancomycin. Oral vancomycin and IV vancomycin are totally different. Oral vancomycin is given orally, so it does not get absorbed in the body. It stays only in the gut, and it's used for specifically for C. diff infection. But if you want to use vancomycin to kill MRSA somewhere else in the body, then you won't give it orally. You will give it IV, because IV is the one which does not go into the gut, but is used to kill the MRSA somewhere else in the body. So oral vancomycin and IV vancomycin is something you need to understand, that oral is only for C. diff and nothing else. If there is listeria, then you can use amoxicillin or gentamicin or cotrimoxazole. And for bacillus species, anthrax and other things, you could use penicillin, doxycycline, or ciprofloxacin. Gram-negative warts, which is a very big group, again, it depends. But again, the hierarchy would be depending upon how resistant the organism is. You could start with amoxicillin, go up to co-amoxiclav, piptaz, and then meropenem is sort of highest. And in between, somewhere comes astrinam, and cephalosporins are similar level with the co-amoxiclav. And then Pseudomonas is a kind of gram-negative rod which has got specific antibiotics only can cover Pseudomonas. Everything doesn't cover. So you'll have to use something like piperacillin, tazobactam, meropenem, ciprofloxacin, or ceftazidime. Even aminoglycosides like gentamicin would work, astrinam works as well. And for Haemophilus, it's a moxdoxy kind of thing. So this is with experience, as you get to know more, it starts getting deeper and deeper. So this is just a bit more explanation of different kinds of antibiotics. So beta-lactams, as I said, there are mainly 4 types: penicillins, monobactams, cephalosporins, and carbapenems. And penicillins could be penicillin G, pen B, or it could be flucloxacillin, amoxicillin, or they could be in combination with beta-lactamase inhibitors like amox and clavulinate make co-amoxiclav, and piperacillin, tazobactam make the trade name is tazocin. That's commonly used. Cephalosporins are again divided into generations. So first generation, you'll see ends in in. So cefalexin is the most commonly used in UK, mainly used for UTIs. Second generations are the most commonly that we use in UK is cefuroxime. And third generations are mainly used like cefotaxime, ceftriaxone, ceftazidime. So first generation cephalosporins mainly cover gram-positives. Second generation cover a bit of gram-positive and a bit of gram-negatives. Third generation mainly cover gram-negatives. Fourth generation cefepime we don't use in UK that much. Fifth generation ceftaroline again not used that commonly. Nowadays newer cephalosporin and beta-lactamase inhibitor combinations are coming for carbapenem resistant Enterobacteriaceae, CPEs, if I don't know if anybody's heard. So those are the ones which are really resistant to most of the common antibiotics. And then ceftazidime, avibactam, or ceftolozone, tazobactam are the combinations that we have to use. And then highest in this hierarchy is carbapenems, which is meropenem and ertapenem. So yeah, again, the same thing. Penicillins would be amoxicillin. It's the same spectrum as benzyl penicillin, plus it has activity against enterococci and H. influenzae. And then flucloxacillin is mainly a most commonly used anti-staphylococcal agent. And then, as I said, beta-lactamase inhibitors are clavulanate and tazobactam, and they, when combined, they increase the spectrum of the antibiotic. And then piperacillin is specifically also active against Pseudomonas. Cephalosporins, again, the same thing that I told you. Cephalosporins first generation, and then second generation, then third generation. Third generation, most important thing is that they've got good CNS penetration. And monobactam aztreonam is a kind of beta-lactam that only covers gram-negative bacilli, but it also covers Pseudomonas as well. Carbapenems are ertapenem and meropenem, very broad spectrum, right on the top. So they cover gram-positives, gram-negatives, and anaerobes. But the broader spectrum, the antibiotic, the higher the risk of C. diff, because they knock off the good bacteria from the gut and give a chance to C. diff to propagate. Aminoglycosides, as I said, gentamicin, tobramycin, they're mainly active against Enterobacteriaceae, Pseudomonas, and staph, including MRSA. And they also have got the synergy with cell wall antibiotics. And if somebody's got endocarditis, sometimes you give gentamicin as a synergistic agent to the beta-lactam. The most important problem with them is side effect is nephrotoxicity and ototoxicity. And that's why if you're giving it to elderly patients, you have to keep that in mind. Quinolones are ciprofloxacin, levofloxacin, and again, very good activity against Enterobacteriaceae. They also cover a few staphs. They don't cover streps that well. And MRSA could usually be resistant. And because they're so broad spectrum, they're highly associated with C. diff. And from antimicrobial stewardship point of view, we try and avoid the use of these broader spectrum antibiotics. Folate antagonists are trimethoprim and sulfonamide, and the combination makes cotramoxazole. Cotramoxazole is specifically used for PCP, the pneumocystis carinii infection, which is seen in immunocompromised patients. But it also covers staphs and streps and also gram-negative bacilli. So nowadays we use cotramoxazole for quite a lot of infections where we're trying to avoid the broader spectrum antibiotics. And cotramoxazole, the good thing is that it's got very good oral bioavailability. So you can give it orally for deep infections like osteomyelitis as well. So that saves the patient staying in the hospital for IV antibiotics. Macrolides, clarithromycin, it's got good staph and strep activity. It is used as alternative to penicillin in, if somebody's got cellulitis and throat infections and they're penicillin allergic, then the next other common antibiotic that comes to the mind is clarithromycin. And specifically for atypical pneumonia, like caused by Legionella, chlamydia, mycoplasma, clarithromycin is the agent. And it doesn't cover any gram-negative bacteria. The lincosamide clindamycin is another agent, which is mainly for gram-positive and anaerobe organisms. It doesn't cover gram-negative, and it's used for staph and streps and anaerobes. And it is highly associated with C. diff, so that's why we try to use it, not to use it in older patients. But it has got good bone concentration. It's well absorbed orally. So if the patient is well enough to go home, they've got cellulitis or some kind of infection, then it is a very good option. Tetracyclines. So doxycycline is another good agent. Tetracycline as such is not used as much, but doxycycline is better. And that can be used mainly for skin and soft tissue infections. It could be used for MRSA infections as well, and chlamydia, and also for malaria. Glycopeptides, we have got vancomycin or teicoplanin, and they are, so glycopeptides, they cover only gram-positive. They don't cover any gram-negatives. and specifically for MRSA or serious infections, when the patient are allergic to other options, then you use them. Linezolid is another broad spectrum gram-positive agent. So, and it covers MRSA, the vancomycin-resistant enterococcus. The only problem, and it's available orally, and it's got very good oral bioavailability. The problem with this agent is that it's expensive, and the other thing is that it can, if used for more than 2 weeks, there is a risk of bone marrow suppression. Fusidic acid is an anti-staph agent, which we definitely have not to use on its own. We have to use it as a second, in combination with another agent as a second agent. Similarly, rifampicin, which is used for TB and against staph as well, we have to make sure that we never use it on its own. We use it in combination with another antibiotic for MRSA or some meningococcal infection or things like that. Metronidazole is specifically anti-anaerobic, and it could be used for bacteria and protozoa. So coming on to clinical application. So if you look at a patient who's got come in with some sort of cellulitis, skin infection, so you think that, oh yeah, skin infection, so I have to cover staph and streps. Diphtheroids are common skin flora as well, but diphtheroids are usually skin commensals, apart from Corynebacterium diphtheria, which we don't see in this country that much. It can lead to, the throat infection. But some patient coming in with cellulitis, you definitely want to cover staph and streps, and then you want to use the agents that I mentioned previously, like Fluclox or clarithromycin or doxycycline or clindamycin, things like that. Somebody's coming with respiratory tract infection, a patient, you definitely want to cover streps. It could be staph as well, or some people carry Neisseria meningitidis in their respiratory tract. They could just be carriers. All sorts of things. Then in respiratory, if it's pneumonia, then it's a totally different thing, and then you have to go into whether it's a community-acquired pneumonia or a hospital-acquired pneumonia. There could be different agents, and then you target that. So it's a vast field. But normal flora in respiratory tract would be staph and streps and yeast, or they could be carriers for Neisseria. The normal flora in the gut is usually Enterobacteriaceae, which is a huge family. And as I said, it could be Klebsiella, Enterobacter, E. coli, Salmonella, Shigella. They're usually not normal flora, but those are the things. But normal flora is just the coliforms like Bacteroides. Then Enterococci could be living in the gut. Anaerobes, staph and yeast could be there. Blood and urine usually would be sterile. So gram-positive cocci, they would usually cause staph and streps. They will cause skin, soft tissue infection. They can lead to endocarditis in the heart. They can lead to pneumonia, bone and joint infections. Any foreign body, any hardware, any metalwork anywhere, they tend to stick onto those and they can cause infection. The gram-negative bacilli, they can cause hospital-acquired pneumonia, ventilator-associated pneumonia. They can cause intra-abdominal infections, perforation, peritonitis. Then you definitely have to cover gram-negative bacilli. And they can also lead to urinary tract infections most commonly, and genitourinary infections. Anaerobes, as I said, they mainly affect, if there's any abscess anywhere in the body, then you have to definitely cover anaerobes, and atypicals, Mycoplasma, Chlamydia, Rickettsia, Legionella, they would cause community-acquired pneumonia. Yeah, so this is like a very, very brief and like a crash course in microbiology, where I gave you a glimpse of different bacteria, the different sites of infection, and the different antibiotics that could be used to. So hopefully I have, I hope you can, at the end of this now, name 2 bacteria in each category, name 2 sites of infections of these organisms, and name 2 antibiotics to treat gram-positive and gram-negative. So I hope we have achieved these objectives. Yeah, so if you have any questions, you can ask me now. You can unmute and I'll try and answer your questions. Any questions? I'm happy to share the talk. If anybody wants, you can send me your email address. I can send you the talk as well. Very quiet, everyone. Any questions? Did it make any sense? Right, okay. Everybody is very, very quiet and shy. If you want, yeah, if you give me your email address, then I'm happy to share the talk with you. But I'm based in Boston side. We've got a small lab in Boston side and a big lab in Scunthorpe side. If anybody wants to do a tour of the lab to see how things work in microbiology, most welcome. Thanks a lot for listening. So I'm on, if you want to, yeah, I can give you the slides. If you share your email address with me, then I'm going to email the talk. That's not an issue at all. So thank you so much. Take care. Bye.